So today we're going to be talking about pain management and the opioid crisis in the emergency department. The special population identified is patients experience pain and opioid risk. Includes chronic pain patients, substance use disorder, and underserved populations. Why does this all matter? Well, for one, the opioid epidemic is still going on. There are still patients that are over prescribed opioids. There are still patients that need opioids that are not getting them. ER is our critical access. So we have patients coming in here that absolutely need the pain medication, and a lot of them can be labeled as drug seeking. And this is kind of the type of things that I want to address is that we may have patients that are not getting the pain medication that they need, one because of the opioid epidemic, but also because we are viewing them as drug seeking. Key issue is personal bias. We may look at a patient and say that they're not in the level of pain that they're in. Fear of the patient getting addicted to medication, which working in the ER, they're not staying here for a long term, but if they need the pain medication, this is probably something that they should be getting. And then the ethical dilemma that our providers face and that we face as well, whether we are getting them the correct pain relief that they need or if we are doing more harm and possibly driving them towards addiction. So the first tool that I want to talk about is the opioid risk tool. What this does is it allows us to screen patients quickly and find out if there's a chance of misuse for opioid with this patient. Does their family have past history? Do they have personal history of substance abuse? Ages, all these different things. What this tool states is the score of 3 or lower indicates low risk for future opioid or addiction results. And this is a tool that we can use for when we're going to our providers and saying this patient needs this medication. We can show them what their past is with this medication. The next tool that we could use is the clinical opiate withdrawal scale. And this is going to assess withdrawal severity, like once they leave our hospital, what are we looking at? How much medication are we going to have to prescribe? Or if we're giving them some quick pain medication for their visit in the ER and then sending them home, are they going to withdraw from that as well? This also prevents undertreatment of withdrawal. So sometimes we send patients out of the hospital, out of the emergency room, and they've been on these high doses of medication. And then we underprescribe them when we're going from high levels of morphine and then giving them a couple Percocets to come off of the medication with. This supports evidence-based care and it improves the outcomes. So again, this is another tool that when we are fighting for our patients and advocating for them, that they're getting the medications that they need and the pain relief that they need. That we have another tool to say, we've screened for this, we've looked at this. And again, these screenings aren't going to take that long. It's not going to add to multiple more times. And then the number one uh, tool that we can use is a numeric pain scale. I know that we all know what this is. One of the biggest issues that we see is on your pain level on a 1 to 10 scale. It's not a 1 to 10 scale, it's a 0 to 10. Are you in any pain whatsoever? If not, that's a 0. And then go from there. You'll hear patients say 1 because that's the lowest number that you gave them, but they may not be in any pain whatsoever. This is a standardized pain scale that is used all over every department. But the nice thing about this is something that can be checked in constantly and it's a quick in and out. And it also removes biases. This is a chance for a patient to advocate for themselves, let you know how much pain they're in, but for us to go advocate for them after we receive this number. And again, this isn't a one time, hey, what's your pain level 0 to 10? Okay, cool. Here's your pain medication. Or it's at a 3 right now. Okay, you come back in 30 minutes later, 45 minutes later, and you can see them grimacing. You can see they're different. You can ask that number again, and it's a quick snap of the finger, and you got the number. You're able to ask where this pain is coming from, or if it's radiating, all these different things, but it allows you to know that you need to dive deeper. Ethical and legal advocacy. The ethical side of this is looking out for our patients and being ethical in the facts that this patient is needed adequate pain medication. They need the the correct part and avoiding the stigma of it all. Um, I think there's a huge stigma when it comes to pain medications, especially in the ER. We're seeing lots of patients that come in that we've seen many, 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 many times. But hey, maybe that one time that they're in there, they are in a 9 out of 10 pain and they are showing these signs and symptoms. Does it mean that we should not give it to them because they've come in multiple times trying to get pain medication in the past? It's up to the provider, and that's where the legality part comes into it as well. Patients have a right to pain medication. They have a right to, doesn't have to, we're not always talking about opioids here, but they have a right to get some of their pain relief. We have to follow safe prescribing laws and ensuring that the patient isn't getting overprescribed. And then in the end, documentation. Documentation can go a long way. Patient stated 8 out of 10 pain, Tylenol given. That is a way that we ourselves as nurses can interject our voice into their charts. So that way, if something does come of it later, we've advocated for them, we've done it, and we've done it the right way and documented it. Social justice within this is there is a major bias towards minority populations, and you've seen it a lot with sickle cell patients that come in that have fought for years and years and years to get the diagnosis of sickle cell, and then they're in for a sickle cell flare up, and they're not wanting to talk about their PRN or their scheduled medication or how early they can get it. They want it at those times. And this is because in the past they haven't gotten the advocacy that they needed. And then we have access to care. Some patients, I've had it in the past when I was in the VA, I could either see my provider in 6 months or I could go to the emergency room because urgent care wasn't available to me. All I was able to use was the emergency room because the VA would cover that, or my primary care provider within the VA, and the system was so backed up I couldn't see them. So my only chance was to come in to the emergency room for smaller issues. And at some point I felt like I might be getting that drug seeking mentality because I was coming in once every 2 months constantly for minor issues. And I would say that I was in a 2 out of 10 pain, 3 out of 10 pain. And I would get some of the same nurses and I would start getting sideways looks from them. But at the same, then I would have to sit there and advocate for myself and say, hey, I understand that this is a minor issue, but this is all that my insurance covers. So this is all that I can do. I'll wait in the waiting room as long as I have to. And so some of these patients just don't have the access to care. And then they're getting some of these labels and these biases that shouldn't be there from the beginning. The next is how to advocate and the use of the evidence-based tools that I showed earlier. Speak up, education, and reduce the stigma. We've got to reduce the stigma of opioids for patients that need them, that absolutely need these medications, and they're not getting them. So we need to advocate for those patients and ensure that, yes, pain medication can be and opioids can be very addictive, but we also need to make sure that they're not thriving in pain because thriving in pain is going to reduce their healing. Quality improvement, as we've gone over before as well, is this is going to help with reduction in readmissions. If we're ensuring that they are withdrawing off the medications correctly and they've gotten the adequate care that they need for pain management, then we can reduce the readmissions that we have here. This can also prevent overdoses or the use of street drugs because they are not getting the adequate pain reduction that they need. And you're going to go say, well, that shows a sign of addiction. But there's been patients in the past that have gone after street drugs and chased down pain medication for themselves because we weren't giving them the adequate care that they need. And in conclusion, the biggest thing is that we have to balance relief and safety. We have to make sure that our patients are safe, that they're not on these high levels that are getting them addicted, but also ensuring that they're not going home and just withdrawing off of nothing and making sure that their pains are met. We need to use these tools and not just assumptions and advocate for your patients. These are the references from this, but I hope that we can all advocate for our patients in the future.